It gives me great pleasure to welcome back to Villanova Dr. Bridgette Brawner. Dr. Brawner is a 2003 cum laude graduate of the College of Nursing. As an undergraduate at Villanova, she distinguished herself in academics with a major in nursing and dual minors in Spanish and psychology. She also distinguished herself as a leader among her colleagues, and as an undergraduate student, she received a number of awards in recognition of her accomplishments. As a new graduate of Villanova in 2003, she went to work at Children's Hospital of Philadelphia in the NICU as a Clinician 1 and a Clinician 2. She served as an intern at South Philadelphia High School to provide counseling and psychological services to students, and she served as a certified medical interpreter in Spanish. She is an advanced practice nurse in psychiatric mental health nursing. Dr. Brawner received her master's degree in psych mental health nursing and her PhD from the School of Nursing at the University of Pennsylvania. As a doctoral student and then as a Distinguished Postdoctoral Fellow, Dr. Brawner became immersed in research, serving first as a research assistant, an intervention specialist, project director, and principal investigator on a variety of studies related to HPV vaccination and HIV infection of underserved populations in Philadelphia as well as Botswana. She has developed expertise in quantitative as well as qualitative research. Her current title at the University of Pennsylvania School of Nursing is Distinguished Postdoctoral Fellow, and I need to tell you that that is not a title that emanates from the College of Nursing. That emanates from the entire University of Pennsylvania. So that's a big deal. She works in the Center for Health Equity Research and the Center for Global Women's Health at the University of Pennsylvania. She is also a visiting research fellow at, lost my page, at an interdisciplinary research on AIDS at the Research Education Institute for Diverse Scholars at Yale University. Dr. Brawner has recently received a 4-year research grant for over $900,000 from the Centers for Disease Control and Prevention, in other words, the CDC, to address HIV, sexually transmitted infection prevention among heterosexually active Black adolescents with mental illnesses. Dr. Brawner will be discussing how she got from here to there, as she addresses from a spark to a flame, igniting your research career. Dr. Brawner. Keeping time.
Okay.
Do you want some water?
No, I'm fine, thank you.
Okay.
So with that introduction, I kind of feel like a big deal to stand here before you with the glowing reviews, but I am humbled and honored just to be here with you. And as we get into my story a little bit, you'll see why it's ironic for me to stand before you to talk about my passion in research. But I first want to acknowledge my family, my mother and my cousin Tina for traveling from Jersey to be here. My entire Villanova family, who aside from Dean Fitzpatrick, I will not go into naming in case I miss anyone that I cannot see in the audience, but I truly value the education that I received here at Villanova, as well as the colleagues that I made over time and the friends who I had an opportunity to get to know. And I also want to thank my husband and my son, who cannot be here, which is probably for the best, because to do this with a 2-year-old hanging off of my calf would not work at all. Just to kind of give you a roadmap, and can I move? Is the live on if I start walking? Yes? Okay. To give you a roadmap of what we're going to be talking about today, I'll first go into my background, just who I am as an individual. So you got to hear the scientific part of who I am, but I'm also a human being, just as everyone else sitting in the audience. And then get into the spark, which is really how my ideas progressed, how my program of research came to be. Go into a little bit of the significance and the impact of this work. Then really my passion, which is research as advocacy. So for me, that's the flame. You know, we generate these data, and then what do we do with them? And lastly, talk about future research. So it all starts with me as a little girl. I grew up in Brooklyn, New York. I've lost my accent by way of New Jersey, but when I'm sleepy or angry, it comes back out. But what that experience did for me growing up in Brooklyn was having a chance to experience firsthand what structural violence is, what it means to live in a community that doesn't have the same resources as another community, or what it is to be economically and socially disadvantaged. And from the time that I was a little girl, I knew I wanted to do something big to help people and to have an impact. I wasn't always sure what that would be, but I knew that it was going to have some sort of ties to the community. I had a chance while I was here at Villanova to do a language immersion program in the Dominican Republic, which started to pique my interest in research a little bit because we had an opportunity to go throughout local communities, and I was speaking with one of the researchers who has a poster here, and in some of the bates to just see, again, that social and structural disadvantage that some people lived with. I also got to travel to Botswana, to do some HIV prevention work, and I've done things here locally, but my passion has always been for young people, particularly young women, and populations that are dealing with social or structural disadvantage. The spark. So, did my bachelor's here, and the professors hate when I say it, not just at Villanova, but in general, but how many people like research by show of hands? Right. Wow, like 5, okay. And how many people like psych mental health? A few more than the research piece. So while I was here, sorry, but I have to say it, I hated research and I hated psych, which is why to stand here right now to talk to you about my program of research just makes me laugh on the inside, because I really did not enjoy it. But I think at that point, even though they taught it and we were showing it in the articles and as we were going through our coursework, it wasn't clicking for me how it was going to be useful. And for those of you who are undergrads, when you're in a nursing program, it's like, give me a blood pressure cuff, give me a stethoscope, like let me just go out and practice. I don't want to learn about these statistics and crunching these numbers, and I'm only here today because I'm going to get course credit for it, so like swipe my card, leave me alone, and let me go back to my room. I was there, so I totally get it. But what happened to me was when I started working in the NICU at CHOP, there were so many young women who were coming in, let's say 14 years old, 15 years old, and they had a baby who was in the NICU, and then 1, 2, and sometimes 3 children who were out in the waiting room. And it just tore my heart. Not that you can't have a child as a teenager, but life is just set up so differently if that happens to you. There's implications for your future education, your earning potential. It just has a significant impact. And so I started to become interested in the psychology of sex. What was going on with these young women that at such a young age they were choosing to have sex, and not only were they having sex, but they weren't having protected sex. Another thing that happened, we were having a high rate of central line infections in our unit, and I was asked to take over our Safe Passage program to decrease those infections. And I started thinking and laughing to myself like, wait a minute, psychology of sex, that's psych, and now you want me to run this research project for our central line infection. These are 2 things that I don't do. But alas, I did psych and I did research. So I decided to go back for my master's because as I was seeing the young women that were coming in on the unit, I really did not understand what was going on. So I said, you know what I need to do? I need a master's in psych mental health so I can get at the psychology of the behavior. What's going on in families? What's going on in individual relationships that is shaping the daily lives of these women? I did my master's at Penn and interned as through the Comprehensive Student Assistance Program at South Philadelphia High School. And I started noticing that this relationship between mental health or emotional state was constantly being tied with sexual risk. So the young ladies that were on my caseload who were dealing with depression or anxiety or borderline personality disorder were reporting significantly more risk behaviors than the young girls who had maybe just gotten into a fight with their mother the night before or were dealing with something with their boyfriend. So it started to just switch this light bulb to say something is going on here where their mental health is affecting their behavior. And so me, I've always, even before I knew what behavioral science was, as a nurse, I always wanted to be able to do something about whatever I saw. So I started thinking, well, I need to do something to design a program, but I don't know the first thing about program design. And to do a program, I'll need some money, so that means I've got to write some sort of grant or something, and these were just skills that I didn't feel that I had enough of. And there just so happened that at the University of Pennsylvania, they were fully funding their doctoral students, so as I started putting all the pieces together, it was like, go to school for free, learn how to do programs to help the young women that I want to work with. You know, this is the no-brainer, this is what I need to do. So I started the doctoral program at Penn, and in that capacity was mentored by Dr. Loretta Sweet-Jamat, who is one of like the premier HIV prevention scientists, not only just in this country but abroad, and got really phenomenal training in qualitative methods, quantitative methods, hearing the voices of the community, because again, I'm 30 years old today, but at that point I was no longer 13 to 17. So I needed to learn the skills to hear from those young women, because their experiences growing up in Philadelphia would be very different from mine, where I grew up. So that was a lot of what my pre-doctoral training encompassed. And then as a postdoc, it's small, but my husband and the little guy are on that slide there. But as a postdoc now, I've had an opportunity just to carve my way to becoming an independent scientist, to write for grants, to write publications, and to really see how can I now use the research that I'm generating as advocacy for the populations that I really care about. And the next steps, July 1, my faculty appointment begins at Penn as an assistant professor, where I will have my hat as an independent scientist to manage the project that was mentioned that's funded by the CDC. So that was the spark. That's how everything got generated. So I went from hating psych, hating research. My girlfriends think it's absolutely hysterical to them now, where I sit doing HIV prevention research with adolescents with mental illnesses, because it all just kind of ironically ties it together. But in the program of research, the core is looking at sexual health promotion in disenfranchised populations. And I try not to be specific to particular racial or ethnic groups, because I feel like what that does is then we say, oh, look at all the risky little black girls or the risky little Hispanic boys, when we know that the core is behavior and it's not necessarily racially or ethnically driven. One arm of my research is to look at individual level factors. So that's things like hearing the voices of the community, looking at not only qualitative methods, so your interviews and your focus groups, but also some survey designs, as well as disentangling that relationship between the brain and behavior. So as I mentioned before, I was seeing anecdotally and then through research that something was happening for people who were dealing with mental illness as it came to them making decisions about sex and relationships. At the social and structural level, again, from my own personal experiences, I became interested in seeing how the historic context of neighborhoods, or looking at some GIS mapping, as well as managing large data sets, could help to even unfold a larger picture of what was happening. Another piece that I'm very passionate about is community mobilization, because again, even though I grew up where I grew up, where I'm positioned in life now is very different. So no matter what the work we do, we can't assume because we look like the population that we want to work with, or that we're similar to them in some way, that we know what their lived experience is. So it's really about tapping into those groups to get the things in their own words, and then mobilizing them to work with you. We don't want to come in as the great saviors to pull people out of their despair, but really in partnership, figure out what their needs are. And then lastly, bringing it all together, and it's nothing against secondary analysis or different methods of research, but for me, I have to have an end goal. I have to have a product where at the end of the day, I can say, okay, because I did this survey or because I did these focus groups, I now can come up with some sort of program to leave you with something tangible to improve your life. In looking at this work, we know that women, racial and ethnic minorities, youth, they're disproportionately affected by so many different sexual health outcomes, from HIV incidence and prevalence, different STIs, unintended pregnancies. These groups bear a significant burden, which has implications for public health and the health of future generations. So if we have young women who become infertile at the age of 16 because of an undiagnosed and untreated STI, or we have people who, right now HIV is the leading cause of death among African American women, 25 to 34, that's an atrocity, I feel, for us to be in 2012 to have these sorts of statistics still happening. We also need to look at the influence of social and structural factors, because if we go back to the school of thought of pointing fingers at individuals, we really miss the mark. because where you live, how you interact, your social resources, all is going to shape not only how you behave, but also the circumstances around you. And then in thinking about, what is the impact of this work? Why would it matter? We know that it's something that has the potential for funding because it's a high priority area for the NIH and the CDC. If we use innovative methodologies, we can understand the decisions that people make. And again, if we can get at why people do what they do, we have a better chance of helping them to live healthier and safer lives. And then for me, that's through developing evidence-based interventions and in a way that's sustainable for the end users in the community. If we think about this being generalizable to other areas, we see things like asthma, cardiovascular disease, diabetes, infant mortality, and that's just sort of the tip of the iceberg. The factors that we don't really go into as much are things like individuals' cultural beliefs, poverty, racism, genocide, generalized apathy. There's so many factors that are below sort of the canary in the coal mine that we see and the inequities in health outcomes for individuals. The flame. My dissertation research looked at individual attitudes and beliefs, and we'll go more in depth with that for a second, but that's sort of, as I was going along the trajectory, I wasn't totally sold about research, but I was warming up to the idea a little bit. And with this study, the interviews that I did for my dissertation, there's nothing like, for those of you who have done studies before, done interviews for studies, when you connect with someone in that intimate space of doing a face-to-face interview or of facilitating a focus group, they're sharing parts of themselves with you. And for me, that ignited my passion because I felt like I was able to do something that not only were they able to get something off their chest, or a lot of the young adolescents would say to me, no one ever asks our opinion, so we just love the fact that you came to talk to us. That made me more interested and passionate in what I was doing. And then with the actual dissertation itself, expanding that to sort of examine the context of sexual risk more. I also started to become interested in biological susceptibility to sexual risk. So if we know, how many people believe that mental health disorders are biological? Biological, okay. And so if we acknowledge that there's a physical change in the brain that then manifests as depression or schizophrenia or anxiety, my hypothesis is that the same is going to be true for sexual risk behaviors or for people who become withdrawn. So I was interested in exploring that. Again, as I spoke about, expanding that to look at not only the individual factors, but also the social and structural factors, and then the full culmination of the flame centering around intervention development. So in the next couple of slides, I'm going to talk about how I said before research as advocacy, because one of the pieces I feel that I missed as an undergrad, and I'm sure she said it, so I don't want to stand up here and say she didn't, my professor. Disclaimer is, I'm sure she said it, but I missed it. But now I get that data generated from research can be used to promote health in communities. So it's not just something that we do to sit in a book or sit on a shelf, but it really can impact the lives of the people that we want to work with. So as we go through the next couple of studies, I'll talk about the connection to my program of research, the methods that I use, and then the notable findings and contributions. So that first arm, the individual level, the aim there is to elucidate salient individual level factors that protect or increase risk for HIV and other STIs. This answered the question, what are the underlying attitudes and beliefs? So again, going all the way back, by the time I got to this part, this was about 3 years after I left the NICU at CHOP, but that question was still burning. How are these young women viewing relationships with their partners? How are they viewing sexual activity? It was a descriptive qualitative study. I used face-to-face interviews with 24 clinically depressed African-American adolescent females. Their mean age was 16, and they were all currently receiving outpatient mental health treatment. I had an interview guide, a questionnaire that they completed, and also the Patient Health Questionnaire 9 is a depression screening tool so that I would have a sense for how severely the young women were impacted by their depression. One of the things that came out was that mental illness and HIV/AIDS are still very highly stigmatized, to the extent that people who need services may not feel comfortable seeking them, either for their depression or for their sexual risk. As one young woman said, It's just you in this dark room, nobody else. Your family's having a good time. They're outside the walls. But also you have family that's near the walls trying to open up, but instead of you letting them in, you're keeping them out. There was also very low AIDS knowledge. The participants only answered 57% of the HIV/AIDS questions correctly. 3/4 of them were sexually active, and they had an average of 2 sexual partners per year of sexual activity. And again, these are 16, an average 16-year-old girls, so you can imagine the plethora of things that they're putting themselves at risk for. The other thing that came out was looking at the overlap between depression and risk for HIV and STIs. It was important to understand those attitudes and beliefs so that we could really get a handle of what was going on with this particular population. The second arm of the program of research was to explore the social and structural context in which relationships develop and sexual behaviors occur. So this now was getting at what is the context of sexual relationships. So we know what the attitudes and beliefs are among the young women, but what happens when they're now paired with their male partner who may have a mental illness himself or who may not. This was a sequential exploratory mixed method study. I had equal emphasis on the qualitative and quantitative data for my dissertation research. The sample total was 128, again, clinically depressed adolescent females, and then I had a comparative sample of non-depressed females with a mean age of 15. Similarly to the previous pilot study, I used a questionnaire as well as that PHQ-9 to do the depression screening. The major things that came out of this were that the depressed participants reported significantly higher risk behaviors than the girls who were not dealing with depression. And the way that I weeded that out, on this screening tool, individuals who scored less than 10 are presumed to be non-depressed. So as I was going out in the community to recruit, those who were non-depressed had to score below 10 on this index, but those who scored above 10 and were in mental health treatment had a higher frequency of ever having had sex, had a greater number of mean sexual partners, and also a greater number of sexual partners under the influence of drugs and alcohol. And if you think about what drugs and alcohol do to your decision making, they would only be even further impaired in their decisions about sex. Non-depressed participants used condoms more frequently. However, one of the interesting things that came out was that there were no statistically significant differences in their attitudes and beliefs. Clinical depression was also a moderator between their hedonistic beliefs, or how pleasurable they thought condoms would be, and whether or not they used condoms at last sex. In the narratives from the young women, there was a fear of abandonment, this search and almost quest for attention and emotional release, which led to an inclination to acquiesce to their partner's demands. That included non-condom use, engaging in undesired sexual activity, where if you pair all that together, you can see where now maybe risk for HIV or another STI could come in. One of the young women said, "It's like you want to give your feelings up to somebody, you just don't know who to give them to, so you'll just do anything that'll make your feeling more better. You'll try anything." So if a woman is feeling so low about herself and so disconnected from other people, and then sex becomes a means of validation, acceptance, and comfort, we can do all the interventions that we want to say, oh, you have to use condoms, you have to limit your partners, you have to abstain. But if they're in a place of having a physical need, in their minds that they need to connect with someone else that way, we would miss the mark if we didn't hear this in their own voice. So we need strategies then that are tailored to this particular population that meet their needs so that we can have the greatest effect on their risk. The third arm, again, is mobilizing communities and then integrating those findings to target the factors that we identify from our research for areas that can be changed. As I mentioned, I started getting interested in knowing whether or not there's a biological susceptibility to sexual risk, But again, in the training camp that I come from, this isn't something that we can just jump into. So knowing the mistrust that exists, particularly within the African American community as it relates to research, I couldn't just now, as Dr. Brawner from Penn, go running out in the street with like needles to draw blood and specimen cups to collect urine, because I had no idea what they thought about that type of research. So I got funding for a pilot study to look at attitudes and beliefs among the demographic that I would want to work with, as well as their parents and guardians, to see what they thought about biobehavioral research. Again, I love mixed methods, so this was a concurrent nested approach with equal weight to the quantitative and qualitative data. And I had a sample of 60 with 37 adolescents and 23 parents and guardians. We had a semi-structured focus group guide, as well as a questionnaire that got at demographics and their specific attitudes and beliefs. As I'm sure you can expect, there was a large degree of skepticism and mistrust for research, with particular concern for guinea pig studies. So these studies that would involve blood, that would involve genetic information, the adolescents and the parents were very leery. I would say the parents were more so skeptical just because of historical things that had happened and they were more knowledgeable, but the adolescents also picked up on those things. So they would say things like, well, I would want to do it, but my grandmother would tell me no. Or I would want to do it, but my dad probably wouldn't let me participate. One adolescent said, you don't know what that person might do with your information. Or a parent, it's like a guinea pig type thing as far as me, because you're experimenting on my body. Some, however, had altruistic motivations toward research. They saw it as a way to learn information about their own health or to help other people. As a parent said, they may find out something and it gives you a fighting chance at that point. And one of the adolescents said, how you can help with a cure for something. So in doing this type of work, general research and then biobehavioral research that involves, any type of biological specimens, we have to acknowledge and validate their fears. We don't just want to say, oh, Tuskegee happened so long ago, or oh, I would never do that to you because, here I am, Dr. Brawner, a black researcher, trust me. No, at the end of the day, I'm still a researcher, and we have to acknowledge the historical injustices that have occurred, and then build that rapport with people so that they can be comfortable with the work that we're trying to do. The positive research attitudes, however, can be bolstered to facilitate participation, and I had submitted a kangaroo application to look at neurobiological influences on sexual risk, and I'm currently revising that to put in a small r because I am so interested in the biological relationship between the brain and behavior, and the data from this pilot study show that they would, in the end, be receptive to that type of work. Another thing that we did, again, me with my behavioral scientist hat, there was just a general lack of research-related knowledge where people didn't know what research was, why it was done, didn't think it was important, and that resonated with me because I remembered sitting in those shoes. So our team with our Youth Community Advisory Board came up with what's called The Real Deal with Research. And it's a 15-page brochure that goes through the who, what, why, when, how, where, every question that you could possibly ask about research, so that we're giving them the information they need to make informed decisions, not being coercive and saying, oh, because we're doing this, you should participate, but making sure that they're not choosing not to participate because of misconceptions that they have. For the in-progress research, I was last year accepted as one of 4 fellows at Yale University to do some research work there, and that looks at individual, social, and structural factors that shape the risk context. This one is a multi-method, multi-level investigation that I get really excited about because it forced me to stretch outside of my comfort zone. If you think about the previous studies that I've mentioned, it's all been focus groups and interviews, focus groups, interviews, and surveys. And this one includes some GIS mapping, some advanced statistical analyses with secondary data, as well as data integration and member checking. And we just had a focus group last night, and it was encouraging for me because for this study, all participants are black, but they were saying it encouraged them to see a researcher that looked like them doing the work. Or even if I didn't look like them, the fact that when they came in, there was no judgment and I didn't have to stand in front of the room, with like Dr. Brawner plastered across my forehead, but I was there with them as they were coming for the session. So and we had some other interesting things happen that I can't share, but research is fun. You get to learn things about people that you probably wouldn't in other contexts. The fourth arm of the program of research is to develop, test, and disseminate multi-level sexual health promotion interventions. So again, this comes back to that question. We've identified all these things. So we know that there's a relationship between mental illness and sexual risk. We know that people can use strategies to live healthier and safer lives. So what do we do about it? Do I just, publish and go on for the end of my days without giving them a tangible product, or do I come up with an intervention? So that's what the CDC grant is funded to do. This, for every aspects of making this relevant as possible, that's what we're going to try to do. So we want it to be gender and culturally relevant, developmentally and psychologically appropriate, so that it's truly meeting these young women exactly where they are. And we also chose to include males in this endeavor because for heterosexual adolescents, who are the girls having sex with? Not rhetorical, you can say it. Boys, right, boys and men on some occasions. So this will be a randomized control trial with a total of 128 adolescents. All, again, will be currently receiving outpatient mental health treatment. And we'll start with team building, elicitation research, and then move into the behavioral trial. So how is all of this going to benefit the public, right? What is this, as Dr. Jamaat would say, so what? You do all this work, and now so what? What is the end result of what you're doing? First, if we think about promoting health equity through biobehavioral research, this has implications for community members because now we can develop, again, those products for the end user. So my goal at the end of the CDC grant will be to have a standard manualized curriculum that can be implemented in the outpatient mental health programs throughout the city of Philadelphia. And I'm with the director for the Department of Behavioral Health for the city to make that happen. As clinicians, I feel mental health and physical health operate in silos. So physical health providers, we're not talking to them about their mental illnesses, and mental health providers, we're not talking about relationships and sexual risk. For policymakers, this has implications for standardizing sexual health assessment and intervention in mental health care. Administrators, again, people who are on the ground level in charge of making decisions about what happens, can look to all aspects of this program of research. Educators, researchers, the continuum goes on, that it has a broad reach to do this type of work. Future plans for the individual level, again, to submit that application to look at the biological relationship between the brain and behavior. For the social and structural context, to do a secondary analysis of the data that I'm collecting now as part of the Yale project. With community mobilization, I'll also be submitting a small R in January to take the pilot study that I'm doing now, to take that up to a citywide analysis. Right now, we've just been doing it in 4 neighborhoods, so we'll set our model to do it throughout the city of Philadelphia. And then for intervention development, the brochure that I showed you that we developed because there was limited information about research, we plan to pilot that to see if it can be effectively used as an intervention to increase research participation or informed research decision making. In summary, research is key to population health. That is something that it wasn't clicking for me until I got out and started practicing and seeing things in the real world. But I learned that findings drive our practice in all settings. So if you want to go into neonatal intensive care, psych mental health, med-surg, whatever you want to do, the care you deliver is going to be evidence-based. It's going to be determined by what people are publishing from their research to say, oh, this is the type of wound dressing that you should use, or this is how you should feed premature infants. Data can be used for advocacy on multiple levels. So if you have something that you're passionate about, think about how research can help you do something with it. If you want to do maternal child health and you were interested in the presentation earlier about postpartum or what happens when children are born premature, you can take that and generate data to do something about it. This one I should have put in red font. Even if you do not consider yourself a researcher, be open to the possibilities. Once I got we had to do research in the master's program and then in the doctoral program, I sat there like, I really wish I had paid attention in 2001 and 2002 as we took that research course, because it just was coming back up. And if I was, being open-minded and had my eyes and ears open to the potential, I wouldn't have struggled so much in those initial stats and research courses. And then lastly, just find your spark and start there. You know, you don't have to look at it to say, oh, well, I'm not interested in being a faculty member, or I don't want to write, you know, NIH level grants. Just think about whatever it is that you're passionate about. And again, be open to how research can help you not only do that, but do it in a way that's going to be most beneficial for the people that you're hoping to help and serve. And thank you.